Hi, everyone. My name is John Faulkner. I'm your host of the Smarter Systems, Better Care podcast. I'm here today with Dr. Stephen Youngblood. He is the medical director at AbsoluteCare New Orleans, where he leads a team in providing high quality, compassionate care to vulnerable Medicaid populations. Thank you for being here today, Dr. Youngblood.
Thank you for having me. I'm looking forward to this.
Absolutely. So, just to give our listeners context, tell us a bit about your background.
Sure. So I finished residency in 2005, moved to Southeast Louisiana outside of New Orleans 2 months before Katrina. So started my career in the thick of it, so to speak. Went through Katrina. I had a practice, was kind of a small area outside of New Orleans, traditional practice. I did that for a few years. Had a friend, we had an opportunity to start a hospitalist program together, which we did. Two physicians trying to make a business didn't work the best, but we got it. We were doing good care. We were learning as we were going. We did that for a couple of years, and then we were working a lot and it wasn't going in the direction we wanted. So we kind of ended that project. That was around 2010. 10 on, I worked as a hospitalist in the New Orleans area at various hospitals. I did that to about 2013. 2013, I joined GenCare, which is a subsidiary of ChinMed, which is a Medicare value-based organization, and kind of worked my way up in that organization. Started off as a physician, ended up as associate medical director, various titles and various responsibilities. And then about a little over 3 years ago, I had an opportunity to come to AbsoluteCare and try the value-based care thing with the Medicaid population. Been going on for a while in Medicare. Now we're trying to do it in the Medicaid space, which is a little bit different and probably a little harder to be.
Yeah, it sounds like it too, especially with government changes that are probably occurring. Do you mind kind of giving us a like a 2-minute overview of that, of like what's happening in the space so far?
Wow, man, there's a lot happening. So just to, quickly review, Medicaid is an insurance that is partially supported by the federal level, right? They give money to the states run it. And after in all that time period where there was a big expansion of insurance and Medicaid expanded in a lot of different states. So in the state of Louisiana, where I reside, we're the second highest percent of our populations on Medicaid. We're second only to New Mexico. Mexico's number one, right? I think they have like 40% of their population on Medicaid. Ours is slightly below that, somewhere around the 35 mark. Well, we know that with the big beautiful bill coming through, that there's some future cuts coming, right? And for the most part, states have been actually kind of struggling with Medicaid and making sure that they have the resources to meet the growing need. Even recently, I believe California had to close their Medicaid rolls and go to some period of time where they're not going to enroll more people. They didn't kick anyone off. They just opted, we were not going to enroll people because we got to balance the state budget. States can't run in deficits. Only the federal government gets to do that. So the states are trying to figure out how to do more with now going to be less. And it's all going to be done. It's going to come to, some significant change by 2027, in the next couple of years.
Yeah. And then because you're focused on this Medicaid population right now in your business, what's the core focus when you're working with Medicaid patients? How do you serve them specifically? Maybe differently than Medicare patients, because you came from that perspective originally.
Right. So, Medicare is our, elderly population. Medicaid's a younger population generally. It's a underserved population. What we do at AbsoluteCare is we actually focus on the highest utilizers, those people that are really going to the hospital, really driving the expense. And we provide kind of wraparound services. And the way I think about wraparound services is it's kind of like there's a couple of key elements. One, you have to be thinking about the social determinants of health, right? Housing, food, other things is going to be a significant portion in this subset of the bigger population, and the highest utilizers, significant portion of behavioral health issues. So bipolar, schizophrenia. So you need to be able to treat them and provide the services for that. there's a pretty high proportion of substance use disorder. So we need to we need to have an ability to provide services on that. And after you do those three things, then you get to talk about your bread and butter medicine issues like diabetes, heart disease. It's really hard to treat someone's diabetes when they are using stimulants or narcotics or whatever they're using, and they're homeless, and they're also, trying to figure out what their next meal is. So you really have to stabilize those three big things. So if this was a table, the skinniest, smallest leg is traditional medicine. The other legs that carry all the weight are going to be, social determinants of health, behavioral health, and substance use.
Yeah, so you're probably trying to figure out how to get them to come back to your clinic and continue care, not just do like a one time and done. A lot of these patients sound like they need continued care throughout the process.
Absolutely. And keeping our patients engaged in this population. They can be a little transient. They can, get lost, for lack of a better term. They have no phones. If they get a phone, it runs out of minutes. Yeah, it's keeping them engaged in their own health is probably the first step of all those steps, right? We gotta get you in, we gotta get you engaged, we gotta make sure, you understand what your risks are. And it takes time.
Absolutely. And like, what's one shift in this like Medicaid industry dealing with the younger population that most leaders are not paying enough attention to?
That's a good question. So I would say that I think we are underestimating the amount of stimulant use that's going on out in the real world. And specifically, I'm talking about meth and cocaine. It doesn't, you don't see people, having overdoses like they do with fentanyl where they die and you see it on the news. Stimulant use is a little more insidious in how it slowly undermines your world. And so I think I don't think it's fully been recognized when you're talking about it. I'm watching, it's getting more and more here, at least in New Orleans, they're recognizing it in the hospitals, but I think it's been under-recognized for a while.
Yeah, and that's a good call out as well, because it can be like habitual. It's difficult to obviously get off of, and then, like you said, you're competing
Yeah.
with patients that also have maybe type 1 diabetes or something very severe on top of this chronic drug addiction as well. It can be very complicated to deal with. So, and then, like, how have you adapted, like, in your own practice? And like, what happens if you ignore this shift that people are maybe ignoring?
Well, I think, ignoring the shift leads to, worse outcomes. That's the
Yeah,
first step, right?
right.
You have to realize there's a problem before you can treat the problem. And I know for the longest time where I was suspecting it and seeing it before this role was in heart failure patients. I noticed a lot of heart failure patients going in, never really understood why. So I started looking and went, oh, they're doing stimulants, it's exacerbating their heart failure. And they end up in the hospital, it's straining the heart, right? But in this role, what I've seen even more of is, stimulant use is exacerbating behavioral health issues, making people appear bipolar or schizophrenic, or or even exacerbating it. So it can exacerbate it, but it also makes people appear to have the diseases when they may not really. They just have it when they use stimulants. So that's been, something kind of unique and to this particular role that I'm in.
Yeah, absolutely. And I'm sure it sounds like it's almost masking what could be really going on as well. And that could be another layer of complexity on top of everything else you're already trying to deal with, trying to figure it out, right? So,
Exactly. Exactly.
and then looking at like operations day to day, where do things feel clunky or slower than you'd like to see happening around in your clinic?
Oh, so every clinic is its own little microcosm of dysfunction. So I would say, um, you know, the it's the biggest thing is scheduling, right? Any clinic, making sure that you start the morning, you have a schedule. I'm going to see these 15 patients today. And what ends up invariably happening, even in a well-run clinic, is something glitches. A patient shows up a little late, shows up a little early, something falls out, and it starts causing a cascade. With the high utilizing Medicaid population, they have trouble being punctual, for lack of a better term. So that patient may walk in early, which is actually great. I'll take early all day long, but when they start showing up later, now you have a couple of patients trying to get into the same slot.
Same slot. Yeah.
So it gets super complex. It makes it difficult. And even like our goal is to get to 12 is to see 12 patients a day, which is not a lot. I mean, your standard primary care doctors seeing 25, 30, they're trying to, hum through slots. We're covering a subset of that. And that's a testament to one, the complexity of our patients' medical needs, but also the complexity of our patients' lives. Some of our patients, New Orleans doesn't have a great transit system, right? We use buses and streetcars, which are none of which are fast. So they miss a bus, they get on the wrong bus, something else happens. It can be quite difficult for them to get where they need to get. We had
Yeah.
a patient on Friday end up going to the wrong place he was staying that night. Like there were two missions, if you will. He ended up at the wrong one, and then somehow managed before the day was over to make it to where he needed to actually be, despite our best efforts to help him. Right? We were trying to oh, let's go find him, but he figured it out on his own and got where he needed to be.
Yeah. So he ended up basically in a whole other part of the day when he was supposed to show up is what happened.
Yeah, yeah, absolutely.
Yeah, that can be difficult for sure. And it's good though, like you said, you only have a certain amount of patients per day that you're seeing, like 12. It's not upwards of 25 to 30, but it also speaks, like you said, the complexity of the patient. You can't really see more than that probably just because of all the things that are going on. You're trying to manage at the same time, right? So,
Right. So, you're talking to them about their type 2 diabetes or type 1 diabetes that's out of control, but you're also trying to manage their life because they're having issues, right? They're worried about losing Medicaid. They're worried, they're sleeping on their auntie's couch. They don't have a house. They're trying to figure out how they're going to feed their daughter. So it's really hard to focus on something when they have that many things going on. And then, if you sprinkle a little bit of severe depression and or substance use on top of it, it gets complex real quick.
yeah, absolutely. And that's, kudos to you for helping manage those patients because they need someone like you to help do that for them. Even to the point of like you literally physically drive out and find them and bring them back. It's probably in some cases. So, because they're getting lost in the transport, like you said, the social determinants of health and that sort of thing. And it sounds like you kind of alluded to it already, but how do you follow up? How do you follow up with these patients successfully, or are they no show continuously? Like, what's your outreach look like for these patients?
So our teams are fairly large, right? So again, if you traditionally a provider team is a provider and an MA or an LPN. What we have a provider, an MA, a registered nurse, and a social worker for each little physician team. That team around 400, 500 patients total. Somewhere in there. It depends on a lot of things. Like some providers end up with like a lot of super sick patients, so maybe we turn that down a little bit, closer to 400. Maybe they don't have as many super sick, or they're a more mature provider, so they go higher up to 500. But 400 to 500, let's say for easy math. We also, on top of that, have a community team, which are additional CHWs, social workers, and RNs to go out into the different places and help recapture or look for these individuals and re-engage them and bring them back. Like one of the easiest places to re-engage a patient is in the hospital, right? Again, we're using high utilizers. We got people going into the hospital. So we have RNs that go into the hospital and talk with them, CHWs, social workers, the whole gambit. And that's one location, but there's others, it's different shelters, homeless shelters, and missions around town. We kind of have to, be thoughtful and do various different things. There's no one plan that will, works great. It's a lot of phone calls, mining information in hospital EMRs to really hone down and go down. It's a lot of hands-on labor. It's not like IT driven yet. We can't figure out the IT solution to going out and catching these individuals.
Yeah. Yeah, exactly. Unless you have literally an AI human, like a humanoid or something. But
Right.
you're not really quite there yet, sounds like. So, but yeah, so and kind of looking at results and bottlenecks, we kind of talked about that a lot, follow-ups, no shows, that sort of thing. What's working really well that you would never want to lose like in your clinic right now?
So I think, when we brought in registered nurses to provide additional support to a lot of our providers and our teams, I think that was actually a pretty significant game changer, you know? So your provider's sitting there on the computer and we're trying to make that's your rate limiting step. You know, it's he's he or she can only do so much in a given day. The more time you have them in front of a patient, the more good that can happen, right? So I actually must say two things. So the registered nurse, in my opinion, was a pretty big step. They filled all the messages. They can call the patients. They can provide, additional teaching, like, you know, especially for like me, who's not very good at wound care. I can just turn to the nurse and go, hey, you know anything about wound care? Can you go look at that wound and tell me what to do? Tell me what to tell you.
Yeah.
And so that helps. The other thing that's really been, I think, a game changer, and I think you could probably, for all the physicians that are using this, I think they would all agree, is ambient listening AI technology for note taking. That really has been like a significant change. Because I remember when I first started my career as a resident, it was pen and paper. We were writing, right? Over the course of that time, from pen, paper to dictation to scribes to all the other technologies. But this last run of ambient listening AI technology, it is really impressive. You can go in there, sit down with a little speaker, have a simple conversation with a patient, and walk out with a pretty well documented note hitting all the high points. And I know the more we use it, each iteration is going to get a little bit better. But yeah, those two things have been really a big game changer for us. I'd hate to see either one of those things go.
Yeah, those are integral. I've heard those similar things in place at a lot of different clinics as well. It's been a game changer for them. And then kind of look at the alternative, what's been harder than expected despite all the effort that you put into it? You just can't seem to move the needle.
Managing the schedule.
Schedule.
Yeah, it's just hard. We're trying various things to try to, maximize the no-show rates, trying to anticipate who's going to show, who's not going to show using different algorithms. It's still just very difficult to like get it right. It always feels like you either overshoot or undershoot, right? You always, no, we didn't get enough in for today, or we way overshot and everyone was frazzled and stressed and the providers are unhappy because they were hurried. So yeah, it's getting that schedule flow, that schedule management piece. Things about providers and schedules is they'll never be completely happy. You're just trying to get them to satisfied. That's all you're really trying to get. Like, okay, that wasn't terrible. If you get that out of one, that's a glowing review.
Yeah, absolutely. Is it like specific aspects of the scheduling that are difficult? Is it like too many patients at the same time or different appointment types that don't seem to match up, or kind of curious?
We do have so different appointment types is, I think, we might have made it a little complex for ourselves with the different appointment types. I do wonder that. But I think it's really just comes down to anticipating who's showing and when are they going to show. We know they said they're coming. Are they coming, right? And are they going to be here on time, or are they just showing up some off time? And what happens if they show up off time and we don't have a provider available? It's that kind of thing, because we're asking a group of individuals to be punctual, for lack of a better term, but it's hard for them to do in their life with the amount of health and social chaos that they have going on. It's difficult.
Yeah, I'm sure. And then if you solved like this bottleneck with scheduling, and anything else that's kind of weighing you down, what would success look like in 6 to 12 months?
I'd say for us, success is we're seeing 12 patients a day, so that's 60 a week. The notes, the documentation is done, so it goes on to its billing component. And the provider NPS scores haven't dropped. That's success. Right now, I always tell people that providers are a limited resource. You can't burn them out. It's not like you can make more. There's a limited resource out there. If you do bad by some, all of them will know. There's a one mind among them. And so I think keeping that morale and that practice satisfaction high for the providers, and still from a business standpoint, getting the productivity right and the flow right, that's the success. That's the sweet spot.
Yeah, it sounds like an ideal state to be in for sure. And like, what would that free up for your team to focus on if you can get through those barriers?
So I would say that what it does by keeping that productivity going, the patients coming in, right? It's going to improve the one thing that every business needs to survive: cash. And so the more cash you add, the more things you can get, right? We can give some back to patients through, new programs, whether it's hiring on more social workers or more CHWs, or provide better technologies, because the technology world of medicine is changing fast right now. It's
Yeah,
changing super fast.
very fast.
And so if we can get better technologies to improve the physician experience just a little bit more, that improves physician retention. Everybody's retention is important, but physician retention is paramount, because you got 400 people that have a relationship with that physician. Yeah, we have an MA, we have a nurse, we have social workers on that team that they also have a relationship with, but their main relationship is with that provider. And so when that provider leaves, it's a hit to that group of patients. I got to go out, recruit another provider, bring them in, get them to learn the new systems, and the patients have to reconnect. It's figuring out where we were in their treatment plans when the old provider left. It's a lot.
Yeah, it's a lot to manage. It sounds like piecing it together, the puzzle, right? The healthcare
Yeah,
puzzle.
for sure. Yeah, the healthcare puzzle.
Yeah. Well, thank you for your time and your insight today. It's been a great conversation, and hopefully you had a lot of fun as well. Where can
Oh,
people
yeah, sure
connect
did.
with you if they want to have a deeper conversation or jump into specific topics with you?
Well, they can reach out to me on LinkedIn. I'm always, it bings on my phone, tells me what's going on. And, reach out to me by email through AbsoluteCare. Any of those ways is perfectly fine. Just drop
Excellent.
by. You can drop by the office and knock on the door if you want. I've had a few people do that.
Well, nice. Well, thank you for your time, and I appreciate it. It's been a great conversation.
Absolutely.